Now, without further delay, let's begin today's event, sponsored by Nuance and hosted by Health Data Management. I'd like to introduce your moderator for today, and that is Jim Erickson. Jim, you have the floor.
Thank you, Adam, and hello, everyone. Welcome to our session today. My name is Jim Erickson. Will be your moderator today, fielding questions and taking notes and helping out with the call. Very briefly about me, I was a longtime editorial director. I've worked with Health Data Management off and on for many years, and these days I'm an independent market research consultant who does primary research, not affiliated with anyone on the call today. But looking forward to this, it's an area of particular interest to me. CDI is an area I study and conduct research on, so I'm really looking forward to today's session on remaining financially viable and improving the bottom line in rural health communities. We want to let you know briefly that this session is available for continuing education credit. There is an attachment among the many attachments in your resources tab at the bottom of this display that will allow you to download a form that you can report and hold on to proof of the session, and then this can be added in a recertification cycle, safe harbor there also. You'll also see in that resources tab that you have some white papers, some good information, and also the slides you're going to be seeing today that you can download for further reference or any questions you have for our speakers today. And we got a couple of good speakers today. You're going to be hearing, first let me go, briefly the agenda here. You'll be hearing about the key financial issues facing rural healthcare. We'll talk a little bit about AI-powered solutions to help capture appropriate levels of reimbursement, optimize documentation, and you get some boots on the ground from Magnolia's CDI story, and you'll hear some of that from Jill Tays, who I'll introduce in just a minute, along with our other speaker, Tony Oliva. And we will reserve some time at the end for Q&A. I'm taking notes. I hope you take some notes too, because it's a good opportunity for you to ask your questions. Anything we don't get to, we will follow up with you, and also we will send you a link to this recording as soon as it's available in a few days. So our speakers today, you'll be hearing from Dr. Anthony, we call him Tony Oliva, who is the physician executive with Nuance Healthcare Division as Vice President and Chief Medical Officer for CDI with Nuance. And you're also going to hear from Jill Tays, who is RN, Director of Case Management at Magnolia Regional Health Center. And with that, I'm going to hand things over first to Dr. Oliva, who's going to get us started on our session today on remaining financially viable in rural healthcare. So, Dr. Oliva, you have the floor.
Great. Thank you very much, and thank you, everyone, for letting us talk to you today about financial viability in rural healthcare and where we position the whole idea of documentation in 2020. And I think I'd like to start with just having a challenge for you. And think about going back and really taking a deep and close look at where your CDI program is today. So prior to coming to Nuance, I spent about 15 years as a chief medical officer on the hospital side, and that experience ranged from critical access hospitals all the way up to academic medical hospitals and systems. And while larger hospitals and systems have challenges that they face today, they pale in comparison to what rural hospitals have to deal with. And one of the biggest challenges for rural hospitals is capturing and getting the revenue that is due you for the care that you're providing. And at the end of the day, that all boils down to documentation. The challenge around CDI is that the world of CDI started before electronic health records. It was a paper world when it started, and the first program that I brought in as a CMO was all done in paper charts. And the way CDI programs have been set up over the years really haven't changed that much when we added in the concept of electronic records. We changed how we sent the information to physicians, but we didn't really take advantage of the electronic record. And as we think about where we are today, even if your CDI program is like it was 3 years ago, you're probably likely to fall behind. And I think hopefully I can point out some of those areas where we can start to take a look at how you can optimize your CDI programs in the year 2020 to meet the challenges that you're facing and keep up with where everyone else is going in trying to meet those same challenges. So when you think about healthcare systems and you think about the challenges that are faced, what we find is actually we still see that health systems are not capturing the reimbursement that they're due. Upwards of 4 to 8% sometimes when we go in and look at programs, even when they have a CDI program. And there's many reasons for this. Some of it is staffing, and again, thinking about rural communities, the ability to identify staff and keep staff is clearly a challenge. And just the ability to get to all the records and stay up to date on the clinical and coding challenges that are presented. We know that physician productivity, even within CDI in a retrospective world, is challenging. Going back into a record the next day to answer a clarification is not the best use of time. And anything that continues to draw down on physician time is going to increase burnout. And again, as we think about rural communities, and recruitment and the challenges of keeping physicians in those communities, that is something that we need to have at the top of our focus in keeping the physicians that we have, let alone finding ways to make the care and workflow that the physicians follow in our organizations, something that they want to come to our rural communities and do. The penalties around value-based purchasing have continued to increase. We had this conversation 10 years ago. Most CFOs really were unconcerned. But as we start to approach penalties and withholds of 6 to 8%, that is a real challenge, especially when we know that margins are so tight. And if we think about margins, in 2016 is the last data we have, and they've continued to go down. We're 2.7%. And I know some of you in rural hospitals are saying, we wish we could have 2.7%. These are real challenges to what we do. And leaving any dollars on the table is just not something that we can live with. And it's something that we need to continue to focus on when we look at the optimization of our CDI programs. And payers have been very aggressive. Lack of documentation accounts for about 65% of medical necessity and or DRG reassignment types of denials. And we find that a lot of times we don't even appeal those denials even when there's opportunity to do so. So all of this matters. It matters because how you're measured from a quality perspective starts with your documentation and your coded data. And your competitors and the press are all looking for that information to make sure that they use to either exploit or affect how they work within a market and try to achieve better market performance against you. So these are all continuing challenges that were not present 10 to 15 years ago when CDI first came in. And as we look at it now, we have to look at CDI in terms of how these things can be managed. And there are a lot of problem areas that we tend to look at, and our goal across Nuance with all of our products is to do the best job we can of getting documentation right the first time. So first time right. At the point that it's documented, at the point where a CDS is doing their work, give them all the tools necessary to get it right then, so we can decrease the rework that has to be done and decrease what's missed. We know that there's been pressure to expand CDI within our hospitals, within payers, and even into the ambulatory world. That's a huge challenge in a human resource-driven CDI program. We know that staffing is a continual challenge, and finding good quality people and nurses especially to manage and run CDI programs is going to be a continuous challenge. So as we think about where we go, we want to think about the workflow and the disruption that's occurred in the physician workflow since the advent of the electronic medical record. And again, like I mentioned, CDI was a paper-driven world. It adapted to an electronic-driven world, but we haven't taken on a lot of the opportunities that especially things like artificial intelligence offer us to improve the workflow and efficiency of the work that we do. So when we think about where we can impact documentation and improve documentation using artificial intelligence, there's two places where we see that opportunity. The first place is obviously with physicians. Can we give them the opportunity to answer clarifications in real time while they're already in the note and documenting while they're taking care and finishing up the care of a patient? If we can do that, then we avoid the retrospective clarification that's going to come the next day. And now we know that we can't do that for everything, but we all know as CDS and CDI teams that there are a lot of bread and butter clarifications that are probably amenable to using artificial intelligence to put in front of the physician. And if we can do that, we can truly impact the workflow for the physician and decrease the amount of retrospective reviews. That also does something else. It also frees up those simple bread and butter clarifications from the CDS team and allows them to expand what they do, looking at quality, looking at performance indicators like PSI, capturing present on admission, and getting deeper into the types of documentation opportunities that require more depth of knowledge and more clinical strategy information to sort of attack and bring to the forefront. So by putting artificial intelligence in the hands of the physician, by putting artificial intelligence in the hands of the CDI team to also maybe prioritize their work, identify through AI which charts are more likely to reap benefit and put those at the top of the work list, present clinical evidence and identify diagnoses that have already been captured and present those to the CDS so they don't have to redo them and find them in the record are all things that we can do to make the CDI team more efficient. We also know that because of value-based purchasing and transparency and all the things that are present in 2020, that other people need to have access to the information that we're providing as a CDI program. So your CDI teams certainly need information to what everybody else is doing, but also where the CDI team is effective and where there may be opportunities and prioritization, as we discussed. But we also know that other people need access to this. Your coding teams need to know what you were thinking so that it makes it easier for them to understand why you might have suggested a possible DRG. Your case management teams having access to a working DRG to help them understand the length of stay requirements and be able to do a better job of planning the care and stay of a patient is of value. The quality team to understand hacks and PSIs, which ones are real, which ones are not real. Were the diagnoses appropriate that may have led to a PSI, or was there a different diagnosis that would have got you out of that PSI? So all these things that the CDI team is doing are vital to improving not just the revenue from the organization, but all aspects of the care that's provided. And we also know that we need to have more or a deeper knowledge base of things that aren't traditionally associated with CDI on the inpatient side. So what are we doing on the outpatient side? What are we doing in the ED? Are there opportunities to support documentation and risk in the emergency department? What about pediatrics? Because they have a whole different set of issues and priorities around CDI. And surgical. Can we make it easier to capture surgical procedures for the physician and get those documented quicker and more accurately to optimize the fees and professional fees associated with the physician, as well as facility fees associated with the program? So this is just another way of looking at the same thing that I just talked about, the need for other people to be a part of the information that's at the hands of the CDI team and allow this to flow throughout the program. So I think we're at a poll question, so I will turn that over.
Great, thank you, Dr. Oliva. Okay, real quick, we're going to ask you just a couple questions today. It'll just take a moment. If you can help us out on this presentation by telling us how effective is your CDI program. Very effective, effective, somewhat, not at all effective, or we do not have a CDI program. If you could select one of those and hit the submit button, I'll give you just a few seconds to do that and remind you that you'll have a good opportunity to ask a few questions today, get them into Dr. Oliva and also Jill Tays, who you're going to hear from shortly. From what you're hearing today, I'm taking notes, and I'm learning good stuff already. So, okay, you've selected one. You've hit the submit button, and I'm going to go ahead and close the poll. Okay, looks like we have a mix of experiences. Dr. Oliva, how does this sort of match up with your experience? A good number have no CDI program, and as many have an effective CDI program.
So I'm surprised at the no CDI program. That's although my guess is those might be community access hospitals, but that is something that still could be a consideration within critical access, especially around the opportunities around using AI. But the other ones, I think we find that most people feel that they could do a little better with what they're doing with their CDI program if they had better tools and more efficiency and maybe more resources.
Right. Well, as a researcher, not surprised to see the range of experience. So we'll take that with us and let you carry on with the presentation.
Great. So I just want to show you a little bit about what we're talking about when we talk about artificial intelligence. The key to all of the artificial intelligence that you're going to see is the fact that everything that we've done is moved to the cloud. And the ability to move to the cloud allows us to interact directly with the client and the documentation in real time, and using the power of being able to have access to hundreds and thousands and millions of different types of documentation to continue to make what we do better. And the being in the cloud has been the one thing that's allowed us to really drive AI to the forefront of what you could be doing in your organizations. So I have in front of you a very simple note. It's a very common, what I would call a pretty common hospitalist note. I'm not going to read through it, but you'll notice down in the assessment here, the physician has noted pneumonia and respiratory distress. And this is just a pretty common note that's been documented. And if the coder were to get this note at this point in time, you'll see that they have a pretty low weighted DRG based on pneumonia and respiratory distress that they could possibly code for. And when we talk about AI, in our world, we talk about Dragon Medical One and Dragon Medical Advisor as being a source for helping us identify where there may be opportunities to improve the documentation of this note while the physician was actually documenting. And they don't have to be using Dragon to document, they just have to have Dragon open. So they could have typed this, they could have pulled it in, they could have used structured text to pull it in. Doesn't really matter, but as long as Dragon is open, we have an opportunity to assess this note for possible opportunities to make it better. And you'll see a little red dot in this, what we call the Dragon bar. And this little red dot has a 3 in it, which means that Dragon Medical Advisor, our physician-facing CDI tool, has found 3 opportunities for the physician to improve their documentation here. So if we look at what it found, we find that it found a respiratory condition. So it's found respiratory distress, doesn't really know what respiratory distress is, that's not very specific. It also found pneumonia, that was not very specific. And it also found a high sodium, but the physician never mentioned hypernatremia in there. So there's 3 opportunities here to be more clear, and we've listed out the things that the physician might be thinking about in order to make that more clear. So if the physician were to go ahead and just answer those questions right then and there based on the documentation that was there, you see that they would have pulled in MRSA pneumonia because they really documented the fact that that was what was going on with the patient, and even had the patient was documented as a likelihood. You see that the patient, the physician documented the patient had chronic respiratory failure and then hypernatremia. So now we've caught 3 diagnoses, and by just capturing that very simply from the physician, you'll see that we flipped the DRG upwards to DRG 178, respiratory infections and inflammation. So that's a pretty big change of 0.68 to 1.27. I mean, don't see much of a change in expected mortality. It's still relatively low at 0.6%, but you do see the geometric length of stay did change. So if we go one step further, we look at that record, we know that there's a lot of other stuff going on here that we could potentially identify in the record. And if you look at this, you'll see that the engine identified a whole bunch of stuff here. In both of these opportunities, one being severe sepsis and the other being septic encephalopathy. So clearly the engine believes that there's other things going on, and now because of this, even though there's no diagnosis of sepsis, the engine's able to present that to the physician and get whether or not they agree, disagree, or think something else is going on with the patient. But they can answer this right now in real time because of the artificial intelligence. And if they do, you'll see that there's a significant change that's occurred. The biggest one for me, from a quality perspective, is you see the expected mortality went up to 9.2% with the capture of sepsis in there, as opposed to where it would have been at 0.4%. So when you're thinking about your mortality indexes, you're thinking about value-based purchasing, that's where this impact affects that, because your expected mortality went up significantly. So when we look at the overall impact on the physician side, we know that we can also carry some of that same technology that identified all that clinical evidence that we put together to ask the physician a clarification. We can do that same thing for the CDS team. And because of that, we can actually prioritize the records in a way to make the workflow much more efficient. We know that only about 30% of the records that you look at have an impact clarification, but you have to look at 100% to find the 30%. So if we can prioritize the ones that are more likely to the front, we know that we can impact your work and your ability to get to records. And we can identify all that clinical evidence so you don't have to find it. We can find it for you and pull it for you to actually start your workday as a CDS inside our CDE1 technology. So I'm going to end there, and I'm going to turn you over to Jill, but I think we have another poll question before we do that.
Right. Thank you, Dr. Oliva. Yeah, we do have another poll question for you here, and we'll keep the presentations moving. How much time do your clinicians spend answering retrospective queries? If you can give us an estimation of that, maybe 0 to 1 hour and so on, and select one of those and hit that submit button. And while you're doing that, I'll remind you that we are recording this session today, and we will provide you with a playback of that via email as soon as it's available. Also, don't forget the resources tab. There's some great white papers to download there, today's slides, and also that the continuing education certification you can fill out and get credit for today also if you like. So if you've selected one of these, with your best of your knowledge, how much time do your clinicians spend answering retrospective queries? Hit that submit button, and I'm going to go ahead and close the poll and show the answers here. Okay, looks like this stuff is getting done very well, as quickly as it can, which is pretty fast, actually, I guess, 0 to 1 hour. So I'll let Jill take over the stage now, see if she has any observations on that with Dr. Oliva, and carry on with the presentation. Jill, you have the floor.
Good afternoon. Thank you so much for having me as a speaker today. And I just wanted to share with everyone our story here at Magnolia. And with that being said, I just wanted to let everybody know that we are a small rural hospital in northeast Corinth in Mississippi, 200-bed facility, and county city owned. We do actually have a GME program, and we produce anywhere from, I would say, 20 to 30 graduates per year, and that is both for medical doctors and doctors of osteopathic medicine. We have CVOR and dialysis with an annual admission census of 13,000 patients per year. And our biggest payer mix, I would say, is Medicare, Medicaid in this facility that we are actually utilizing our CDI program for. And we do, too, also have a dialysis program here at the organization, and we are a level 3 trauma center. Some of the challenges that we've actually had at Magnolia over the last, I would say, since 2015, 2016, was getting physician buy-in with a CDI program. Our initial program that we had started back in 2014 was with another vendor that had recommended that we utilize 2 trained CDI staff nurses that basically functioned out of an office and had very little face-to-face interaction with the physicians. At that time, we didn't have any idea that that process or that type of approach would not be as effective as what we utilize today. And we were actually being directly impacted by what I say is the new face of healthcare. And what I mean, or I'm referring to, is the governmental changes with value-based purchasing and the financial incentives versus penalties that were being pushed out to all organizations. That was, I guess, the biggest impact that drove us as an organization to move to a new CDI program. We had actually went away from the initial program that we had implemented and just reabsorbed those CDI staff into the case management utilization process in the case management department. And we actually restructured the organization. Prior to implementing this program, we had reported to nursing, and this year, it was in 2015, 2016, we actually realigned in the organization, and we were realigned to report to the Chief Financial Officer. And he didn't really know much about a CDI program, and so I guess that's why we really moved away from the initial one. And it just gave us an opportunity to look at case management, CDI, from a different perspective. Another one of the biggest challenges that we also faced was the need to improve case mix index. Our case mix index at the time of our initial baseline that we had received from Nuance was 1.44, which compared to our peer group had significant margin to improve. We looked significantly worse from a risk of mortality and severity of illness perspective, and we knew we had opportunities there. Our medical case mix index at that time was only 1.09, and our surgical case mix index was 2.45. And combined cumulatively, it was 1.44. So that was the second biggest challenge we faced. The third being the quality and patient satisfaction scores couldn't really reflect those metrics from our patient population due to the fact that we weren't capturing the most correct data from our clinicians here at the organization. And that was one of our biggest opportunities that we saw to get buy-in from our physicians, was to improve our quality of care and utilize that as a driver to help us motivate physicians to help us improve the organization as a whole, not just a financial perspective. Our actual CDI medical director, we didn't have one with our first program, but the one that we had chosen for the succession of the implemented CDI program with Nuance was very passionate about making sure that physicians understood how what they documented impacted the organization as a whole and the patient population. And so we felt like it was our job to show them that connection between the coding world and CDI, as well as what they actually put into the medical record and how it impacted our outcomes for readmissions, mortality, quality. And I don't think anyone had ever really had shared that information with them. So we chose that as a big driver to help us gain buy-in from them. Another opportunity that we had during that time was CDI productivity and efficiency. We knew that had to be improved and improve the communication that we had with our physicians and our medical staff. So many times, I believe organizations, especially rural organizations that may not have the resources available to have specific dedicated teaching about governmental changes, CMS changes, changes with guidelines in healthcare that are going to impact physicians. We just didn't have that opportunity, and we felt that it was our responsibility to help them see the need for change to help us succeed in value-based purchasing. And back to when the restructuring occurred under the CFO, we actually, I helped manage the coding department as well, and during that time, ICD-10 came out. And what we realized was that coders, went to school to be coders, and with what ICD-10 had put into place, it had completely changed that game as far as how they actually looked at the medical record. It actually had more so a anatomy and physiology aspect as a whole. Moving forward, our decision for vendor selection was actually brought to me by our IT department, the chief information officer. We were already currently utilizing Dragon Medical One and had such a success rate with the utilizations from the physicians that they offered, because we wanted to keep as many consistent programs in the organization as possible. So they came out, they did a demo, and we're again recommending the 2 CDI specialists at that time, and that was something that we had to discuss and determine whether or not that was the actual, route that we were going to take. We were on Meditech 6.1, and we knew that Nuance had the capabilities to interact with that program, the interfaces, everything. We already had that established relationship with them, and during which time Nuance, we had several discussions about other options, other alternatives, but it just seems that Nuance was willing to do whatever the organization needed to succeed and help us meet those metrics. So I don't know where we would be at today had we not have made that decision, had I went with the other program that I was actually looking at. I had looked at several different ones and had a history of being, utilizing a different product as well. When we actually moved forward with the process of implementing and establishing Nuance as our CDI program, they worked with us. I know one of the things, I guess, too, they had a best practice, and we had done that program with the 2, but being a rural healthcare organization, we didn't have the luxury of being able to add additional staff. Financial penalties, decrease in volumes were fluctuating, and we had to make the decision to utilize existing staff. And with that, our CFO, which, again, was my boss at the time, I had presented to them, whether or not we could actually train our existing case managers. Because we were in the records with, 24/7 24/7 practically. Anytime we were here, we had to be in the records, making sure that patients met guidelines to be inpatient observation. We were nurses. We knew when new additional diagnoses were, showed up on the X-ray, lab work. No, we're not physicians, but, we had a different level of care than what a coder or a different level of knowledge as opposed to a coder, and being able to make or ask physicians for additional explanation of possible diagnosis that were in the medical records. And we, again, chose to utilize existing staff, which was 9 case managers that were trained, that Nuance agreed to train. They actually worked with me because that's what I was determined to do. Since we were already in the records, it only made sense to me because I knew what their capabilities were. And they brought additional staff on site for us. I believe they brought 7 consultants compared to 2. It was 7 or 8, and they were on site for 4 weeks. The coders and the case managers had 40 hours of training for the CDI program, and it actually gave them a foundation to start from, and they had never had any type of coding training prior to this implementation. And once they had the training and the consultants were here on site, they answered any questions anytime we had calls or, problems. Somebody was here to help us, to answer our emails, to explain, the impact of different diagnosis versus the coding world, and actually helped us formulate, what those queries might look like, and meet with those doctors and help explain to the doctors why they were why those diagnoses were appropriate. They also, if ever on our reports that they had actually created, we would send in our data monthly. If ever there was a drop in our case mix index or volume shifted, they were reaching out to us to make sure or to understand the rationale behind what had happened during that month for that case mix to drop, and were providing us with additional alternative opportunities or ideas to look at to make sure that we were back up to the baseline that they had set us up at. And I believe so our baseline was 1.44. Our goal that Nuance had set for us was 1.56. And it was an almost guarantee that they could help us meet that. And they actually did, and we actually succeeded the metrics that they had put into place with us during that time. There is, sorry. I think I got off track there as far as my, is the dashboards are up currently. Is that correct?
Yes.
Yes, we're seeing that.
Okay. I just wanted to make sure I had accidentally pushed the wrong slide, sorry. So these dashboards that you're actually seeing currently are some of the tools that we utilize to help our physicians to get the buy-in from our physicians. We knew that quality was a driver for those physicians, and we had to get that quality metrics into a format that the physicians would understand. And our medical director had felt like by using risk of mortality and severity of illness and showing the physicians the impact of adding diagnosis that the CDI specialist had formulated or, had queried for actually made a difference with the patient's severity of illness or risk of mortality. And those dashboards, of course, at that time were created internally, and I actually went to the medical staff meeting and showed the entire medical staff the changes that just by adding specific diagnosis, how that would have impacted a patient's medical record, severity of illness and risk of mortality, and their case mix index. We know that severe diagnosis don't always impact risk of mortality or severity of illness, but we actually showed them how it would impact, and it was actual patients that had expired, and showed them missed opportunities with what was actually coded and finalized and sent to CMS versus what would the patient have looked like had they had documented the appropriate diagnosis during the hospital stay. And, you know, the majority of the doctors were just, you know, at all that they had not documented. They knew the patient had those diagnoses. They just didn't document the appropriateness. And that was the first initial buy-in that we had received, mainly from our medical staff. And from that point on, we developed the dashboards for each section meeting, that whether it was medical, cardiac, or OR, we created those for each individual section meeting. And with the creation of these dashboards, and we would usually do this quarterly, we had several, sub-areas that we had looked at. We would actually show from a high-level organization the overall engagement, healthcare quality, which was basically the risk, mortality, and severity of illness, and then the actual performance, which was your case mix index. And you can see here that on the data-driven outcomes for performance, this is one of the metrics that we chose to present to our medical staff on their actual individual dashboards, the CCs and MCC capture rate, just to show them where we were when we started and where we had gone with the implementation of the CDI program. So not say that we were trying to capture any more or, you know, than what was necessary, just to show them that this is where we missed the ball. And those were the opportunities that were making the impact and the difference for our patient population here in Mississippi. And we also showed them with the case mix index. You can see here 2017, 18, and 19, the results were significant from the time that we had implemented in September 2017 to where we're at today. And our volumes have shifted. We did get to a plateau, but we still are doing great with our program that we have. Last year, fiscal year 19, we actually ended up at 1.59 case mix index, which was over what we had been projected by Nuance when they actually did our data analysis of our previous or for our baseline year. And with that first year implementation, I believe it was not only just the risk of mortality and severity of illness, but from a CFO financial standpoint, it helped our bottom line $3.5 million that first year in each additional year. And currently, I believe we're at 1.6 trending for this fiscal year. So, again, we've got more years to come with CDI, and we'll continue to grow. And we did choose to look at our 80-20 rule to get our biggest bang for the buck as far as implementing this program, and that was on our physicians that we knew would assist us with the program. And every organization is going to have physicians that don't actually, you know, want to participate, that won't answer your queries, but those aren't necessarily the ones that we focused on. And it's very important to make sure that you get the right people in the right place. And I believe we have a poll question that needs to be asked.
Sure. Thank you, Jill. I'm going to go ahead here and push this poll question. We're going to conclude with some best practices for you all, and then we'll have a couple minutes for Q&A, whatever we can get to today. But let's go ahead and answer this last poll question real quick. How effective was your CDI program? For those of you who said you had one, very effective, somewhat effective, and not at all effective. Please select one of those and hit the submit button. And like I say, we'll have a few minutes for Q&A and a wrap-up after we go through some best practices here in a moment. And also remind you that we'll send you the information we have, and use that resources tab at the bottom to get your download of all the papers and information we have for you today. Okay, I'm going to go ahead and close the poll. Okay, so we have a mix of outcomes here. Jill, how did you feel at your organization? How do you feel about these experiences of about half people somewhat effective?
Somewhat effective of their CDI program. I just feel like, there's opportunities, and you just have to look at your organization as a whole to determine, whether what was, set for you by an organization or a company is actually where you're getting your best results. Do you have internal staff that can do the job that physicians relate to, that physicians trust, and focus on that 80-20 rule again, focus on those physicians that are willing to actually participate with a program to get your biggest impact for a quality incentive as much as a financial, gain. Just
right.
Relook at the program as a whole.
Yeah, and those different drivers, the financial side, the clinical side, etc. All right. Well, why don't you close us out with some best practices here, and we'll have a minute or two for questions before we wrap up today. So, tell us about what you have for takeaways here.
So, again, really hold true to the fact that, with an organization, those people that work in that organization know the biggest opportunity for improvement and who those clinicians are that the physicians, actually trust. And if you have CDI departments, CDI personnel and coding staff, get all of those people on the same page. Make sure that they're up to date where they need to be with understanding, the coding guidelines as a foundation. If they're not up to speed where they need to be, they definitely need further training, such as Nuance. The didactic training was awesome. We're actually getting a couple of our new staff members trained as far as the didactic training again, even though we've implemented it in 2017. It really is impactful, and, even reorganization, changing those CDI, the coding, case management, and aligning under the CFO, that financial avenue to help drive your organization for value-based purchasing and quality outcomes. And then as a physician, choosing a physician champion, again, I feel like is very, very an essential part of a CDI program. The one that we had chosen had been a resident here with us in our GME program, had graduated. When he was a resident, he was constantly asking me or one of my the staff members, more about documentation and what they needed to do to get it in the medical record. He was just always curious, and he ended up being the person that we chose because he was passionate about making a change and helping other physicians understand the impact of what they put in a medical record, how it makes an organization as a whole look, and to create that patient population for himself and the organization as a whole. And then, again, keep, as far as your department, keep financial, or not just financial, but keep dashboards, metrics that you can look at daily, that you can review with your staff, you can review with, your senior leadership, your organization as a whole. We reviewed, our dashboards monthly at a senior leadership level, weekly with staff, and then we shared that with any department that needed it. We shared it with the physicians, which I feel like we leave out a majority of the time. And then just, again, look at your 80-20 rule. Where are you going to get your biggest impact, and with who, and what area is that going to be for your organization? And I just think it needs to be individualized for an organization as a whole.
Right. Yeah, I think those are all great takeaways. And you talked about that physician frustration, getting people to buy into new, the workflows that they're used to is what they're always going to fall back on. So making this happen, some change, realignment. I guess we'll just have just a real quick QA, just 30 seconds or a minute with Dr. Oliva, too. Dr. Oliva, it was really interesting what Jill was saying about buy-in and getting people to actually use this stuff. What do you take away from her presentation?
Yeah, so my history is I never talk to physicians about how the performance of our CDI program was going to affect the hospital financially. Most of the time they really didn't care. No. But what I did do is talk to them about how this was going to make them look clinically. And what I can tell you about physicians is they are very competitive, and they will move much more quickly on quality than they will on financial. So if you tell the joke is if you have 100 orthopedic surgeons in the room and you ask who are the top 10 orthopedic surgeons in this room, all 100 will stand up. Physicians are not going to. If you tell them they're doing average, they're probably going to need to start Prozac. They don't like to be average. They certainly don't like to be below average. And if you can show them that they have an opportunity to improve quality numbers just by getting the appropriate documentation that they truly don't understand, they'll do it because they don't want to be seen as being behind their peers.
Exactly. Okay, I wrote that down and underlined it. Quality over financials with the doctors. We got it. Message received. Okay. Well, we are out of time. The good news is you're going to be able to get more information on this. All this that's going on today. We'll follow up with any questions we weren't able to answer today. Natalie Holtgreff from Nuance is here also. She's going to just give us where can we find out more about this stuff, Natalie?
Hi. I just wanted to thank everyone for joining the webinar today and learning more about CDI. And so if you wanted to contact us after this, you can obviously visit our website or call the 877 number that's there. And then we will be at HIMSS in a couple of weeks in booth 1944 if you wanted to stop by and see a demo, not just of this, but of any of our products.
Great. Okay, thank you. Well, great presentation today. I really definitely want to learn more about this myself. I want to thank our speakers today, Jill Tays, Director of Case Management with Magnolia Regional Health Center, for sharing, the experiences that they're going through down there. Really helpful stuff. And Dr. Tony Oliva, the Physician Executive with Nuance Healthcare Division, Chief Medical Officer for CDI. Again, thank you to our presenters, and thank you to all of us for staying with us today throughout our presentation. I hope you got as much out of it as I did. And with that, I'm going to say thank you. On behalf of Health Data Management, I'm Jim Erickson for HDM. Say so long, everybody, and have a great week.